today we're tackling something that is, I mean, it's arguably one of the most iconic images in all of medicine.
Oh, absolutely. You've seen it 1,000 times.
You see it in every movie, usually right before something dramatic happens. You see it in documentaries, on the monitor, next to a hospital bed, glowing in the dark.
It's the universal symbol for I am alive, that rhythmic beep.
Exactly, the squiggly line. But here's the thing, and this is really why I was so excited to dig into this particular chapter you sent over. I realized I've been looking at that line my whole life, and I had absolutely no idea what it actually is.
Right.
I mean, I get that it's the heart beating, sure, but why does it go up? Why does it go down? Why are there these little bumps and then that one enormous spike?
Right.
And, what does the flat line actually mean?
It's a really common experience. We see the result, the graphical user interface of the body, but we rarely stop and try to learn the language it's written in. And that's really what we're going to do today. We are decoding Chapter 11, Fundamentals of Electrocardiography. We're going to try and demystify those squiggly lines and understand the electrical language of the heart.
Okay, and just to set the stage, before we even get into the P waves and the QRS and all the math, which is surprisingly cool, by the way, I have to ask the most basic question. I think a lot of people are probably a little embarrassed to ask it.
Go for it.
When they hook you up to that machine and they put those little stickers on you, the electrodes, on your chest, your arms, is the machine putting electricity into you? Is it shocking you?
That is a great place to start. And honestly, it's a very logical fear if you don't know the technology. But the answer is no, absolutely not. The machine is not shocking your heart.
Okay.
It's actually the other way around. Your heart is shocking the machine.
The heart is shocking the machine. Okay, let's unpack that. That sounds intense.
Well, in a manner of speaking, it is. The electrocardiogram, the ECG, is simply a recording of the electrical potentials that are generated by the heart itself.
So my heart is a generator.
Your heart is an electrical generator. It's a biological battery that discharges on a very precise schedule. And the current that it produces, it doesn't just stay neatly inside the heart muscle, it spreads.
It spreads where? Because I tend to think of my heart as this, self-contained unit inside my chest.
It is, mechanically, but not electrically. That current spreads out into all the tissues that surround the heart. And here's the key bit of physiology. Our bodies are mostly made of fluid.
Right, salt water, basically.
Exactly. It's not pure water. It's this salty, mineral-rich fluid, which means highly conductive. So that little electrical pulse that starts in the center of your chest, it conducts through your lungs, through your blood vessels, through all the fluid between the cells, all the way out to the surface of your skin.
So when I'm looking at those electrodes, those stickers, they're not transmitters. They're receivers. They're basically just sensitive little antennas.
Precisely. They're listening. We place electrodes on opposite sides of the heart, say on your right arm and your left leg, and those electrodes are just capturing the tiny electrical potential difference that manages to make it all the way to the skin.
Wow.
The ECG machine at its core is just a very, very sensitive voltmeter. It's measuring the voltage change from one side of your body to the other, all caused by that little engine inside your chest.
That kind of blows my mind. We're just talking fluid conductors. It really changes how you think about the body. You're not just solid matter. You're sort of a bag of salt water broadcasting a signal.
A broadcast that hopefully never stops.
Hopefully. Okay, so we've established we're listening to the heart's broadcast. Now let's look at the message itself. The source material highlights this very specific pattern that repeats over and over. They call it the alphabet of the heart.
Yes, that's a good way to put it. If you look at a normal ECG, like the one in Figure 11, of our text, you'll see three major components in every single beat. We call them the P wave, the QRS complex, and the T wave.
P, Q, R, S, and T. Not exactly A, B, C. Any reason for those specific letters?
It's mostly just historical convention. They were the letters Einthoven and others used when they were first labeling these deflections on the graph, and they just stuck. But they tell a chronological story of one single heartbeat.
And it always starts with the P wave. That's the first little upward bump.
Always. The P wave.
So if I'm reading the script, what does P mean? What's it saying?
The P wave represents the electrical potentials that are generated when the atria depolarize.
Depolarize. Okay, we're going to be using that word a lot today, I think.
Yeah.
So in the simplest terms, that's the electrical trigger, right? The activation signal.
Correct. It's the electrical activation. Think of your heart as having two floors. The top floor is the atria, the two smaller chambers. The P wave is the lights turning on in that top floor.
Okay.
And the timing here is absolutely critical. The P wave, the electrical event, happens before the atrial contraction actually begins.
Right, that's a distinction the text really emphasizes. The electricity comes first, then the muscle moves.
Always. It's the command to contract. So you see the P wave appear on the screen, and then a fraction of a second later, the atria physically squeeze and push blood down into the ventricles.
Okay, so P wave is the command for the top chambers, the atria, to get ready and squeeze. Then we get the big one, the part everyone recognizes, the QRS complex. Why is this one so much bigger?
The QRS complex represents the potentials generated when the ventricles depolarize. The ventricles are the bottom floor, the main powerhouse pumping stations of the heart.
So more muscle equals more voltage.
Exactly. The ventricular muscle mass is so much larger than the atrial muscle mass, so the electrical signal it generates it's much louder. It's a bigger battery discharging.
And just like the P wave, this big QRS spike happens just before the actual pump.
Yes. The QRS is that electrical trigger spreading like wildfire through the ventricles. It happens just before the ventricles actually contract and squeeze blood out to your lungs and the rest of your body.
So P is atria, get ready. QRS is ventricles, go. And then after that big spike, there's another little bump, the T wave.
The T wave, right. This one's interesting. It's a slightly broader, usually lower bump that happens after the big spike.
And this is where it can get a little confusing, right?
Mm-hmm.
Because the text says P and QRS are both depolarization waves. They're the go signals. But the T wave, it's something different.
Very different. The T wave is a repolarization wave.
Repolarization, so
Yeah.
recovery, a reset.
That's it, exactly. It represents the ventricles recovering from that massive electrical discharge. They're resetting their electrical state, essentially recharging the batteries so they're ready to fire again for the next beat.
When does that happen?
It usually occurs about 0.25 to 0.35 seconds after the depolarization, after the QRS.
So if we look at the whole timeline of a single beat, P wave is the atrial trigger, then a short pause, then QRS is the ventricular trigger, then the ventricles contract, and then the T wave is the ventricular reset.
That's the basic sequence, yes. But to really get why the line is doing what it's doing, why it goes up, why it goes down, we have to zoom in, way, way in. We need to look at the physics of the spark itself.
This was the part of the reading that really made me stop and just think. Section 2 of our outline, where it looks at figure 11-2, it simplifies everything down to a single cardiac muscle fiber. Because looking at the whole heart is just chaotic, but one fiber makes it so much clearer.
It really does. Imagine a single strip of muscle, like a microscopic cylinder. When it's at rest, just waiting, it has a certain electrical balance. But when that signal to contract arrives, we call that depolarization.
And the diagram shows this with colors, right? They use red to show the change spreading.
Right. Imagine that depolarization as a wave of redness moving across the fiber from left to right. Now let's be really specific about the charges, because this is what explains the graph. When a cell is resting, the outside of the cell membrane is positive.
Okay, so resting equals positive on the outside.
Got it. Correct. But when the cell depolarizes, that polarity flips. The inside becomes positive and the outside becomes negative.
So depolarized equals negative on the outside.
Exactly. So as this wave of change moves from left to right, you create a boundary. To the left of the boundary, the outside of the fiber is negative. But to the right of the boundary, where the wave hasn't reached yet, the outside is still positive.
Okay, so we've got this moving boundary.
Yeah.
And we've got our voltmeter, our electrodes, on either end of this fiber, one on the left, one on the right.
Exactly. Now, here is the absolute crucial concept that explains the entire jagged line. Current only flows, and the pen on the graph only moves when the muscle is partly polarized and partly depolarized.
Wait, say that again. Only when it's mixed, when it's in a state of change.
Yes. Think about it. If the whole fiber is at rest, what do the electrodes see?
They both see positive on the outside.
Right. The one on the left sees positive, the one on the right sees positive. The difference between them is zero. The pen just sits there, flat on the baseline.
Okay, makes sense.
Now, imagine the depolarization wave is exactly halfway through the fiber. The left electrode is now seeing the depolarized part, so the outside is negative. The right electrode is still seeing the resting part, so the outside is positive.
So now there's a huge difference between them.
A huge potential difference. You've created a negative pole and a positive pole. Current starts to flow from negative to positive, and that is the moment the meter records its maximum positive value. That's the very peak of the wave.
So the tip of the QRS spike is literally the moment when the ventricles are exactly half activated.
In this simplified single fiber model, yes, it corresponds to the moment of maximum electrical difference, maximum heterogeneity.
But then the wave keeps moving, right? It doesn't just stop halfway.
It doesn't. It continues moving to the right until the entire fiber is depolarized.
Now, what do the electrodes see?
Um, the left side is negative, and now the right side is also negative.
They're equal again.
So the difference is 0 again, and the line goes back down.
The line comes right back down to the baseline. That is so counterintuitive. I think most people, myself included, assume that as long as the heart is squeezed, as long as it's active, the line should be way up high. But you're saying the line only goes up during the change? Once the change is finished, even if the muscle is fully activated and contracted, the line goes flat?
Precisely. That is why the QRS is a sharp spike and not a long, flat plateau. It records the event of the electricity spreading, not the state of being depolarized.
That makes so much sense now. Okay, so that explains depolarization, the P in the QRS. But then we have the T wave, the reset, repolarization. And in the single fiber model in the text, this was fascinating because the graph, it flipped, it went down.
This is figure 11-2, parts C and D.
Right. So the whole fiber is depolarized, negative on the outside. Now it needs to go back to normal. It needs to become positive on the outside again.
Correct. And in a simple model, like a single fiber in a petri dish, the repolarization starts from the same place the depolarization started. So the left side recovers first.
So the left side becomes positive on the outside again, while the right side is still negative on the outside.
Exactly. So now let's compare this to what happened during depolarization. In depolarization, the left was negative and the right was positive.
Right.
Now in repolarization, the left is positive and the right is negative. The polarity is the complete opposite.
And because the polarity is opposite, the pen on the machine moves the other way. It goes down instead of up.
Yes. In this specific single fiber model, the repolarization wave is recorded as a dip, a negative wave.
Okay, but here's where I got a little tripped up reading the text. Because in this simple model, the repolarization wave went down.
Yeah.
But on a real-life ECG, the T wave, the ventricle's repolarization wave, it usually goes up. It points in the same direction as the QRS. It's just a bit fatter. Why is that? Why the difference?
That is one of the most elegant and initially confusing paradoxes in cardiology. It all comes down to the complexity of the whole heart versus a single, simple fiber. In the actual ventricles, repolarization doesn't happen in the same sequence as depolarization. The direction is different.
The text mentions something about the outer surface, the epicardium, versus the inner surface, the endocardium.
Yes. The depolarization wave, the QRS, it starts on the inside wall of the heart and spreads outwards. Think of it like first in, last out.
Okay, inside to outside.
But repolarization is different. For various metabolic reasons, the outer surface of the heart, the epicardium, actually recovers first.
Wait, really? So the very last part to get the activation signal is the first part to recover and reset?
Exactly. It's a last in, first out system. The wave of recovery, the T wave, travels in the opposite physical direction of the wave of activation.
Let me try and process that. Okay, so repolarization is already an event with the opposite polarity, which would make the wave go down.
Right.
But it's also traveling in the opposite physical direction. So does a negative times a negative equal a positive? Do the two opposites cancel each other out?
You got it. It's a double negative. You have an opposite polarity event plus an opposite direction of travel, and the result is a deflection in the same direction on the graph.
That is some serious vector physics right there.
It is, and it's the reason why a normal, healthy T wave stands upright. In fact, this is clinically huge. If a cardiologist sees an inverted T wave that goes down in leads where it should be up, that is a massive red flag.
What does that mean? What's gone wrong?
It usually means that last in, first out sequence is broken. And the most common reason for that is ischemia, a lack of blood flow to the heart muscle. If the outer wall of the heart isn't getting enough oxygen from its blood supply, it can't recover as fast as it's supposed to. The timing gets thrown off, the sequence flips, and the wave on the ECG flips.
So the orientation of that one little T wave can tell a doctor about the metabolic health of the muscle wall itself.
Precisely. It's like a tiny report card on cellular health.
That's incredible. Now, sticking with this idea of what the ECG does and doesn't show, the source material points out another big discrepancy. If you could stick a tiny electrode inside the heart muscle, which they call recording a monophasic action potential, the graph looks totally different from the ECG we see on the skin.
It does. Figure 11-3 shows this perfectly. If you measure the voltage from inside the cell, you see it shoot up and then it stays up for a while. It creates this long, flat plateau.
But plateau?
That plateau phase represents the entire time the muscle is actually physically contracted. It lasts for about, 0.25 to 0.35 seconds.
But the ECG on the skin, the one we see in the hospital, It shows a sharp spike, the QRS, then a flat line, and then the T-wave bump. It misses that whole plateau.
It doesn't miss it.
Yeah.
It doesn't record it as a deflection. Remember our fundamental rule, the machine only records electrical differences.
Right.
During that plateau phase, the entire heart muscle is uniformly depolarized.
Everyone is shouting at the same volume, so to speak.
Exactly. Current isn't flowing between regions because everywhere has roughly the same electrical charge. So since there's no difference to measure, the ECG shows a flat line. We call it the isoelectric line.
It's the silent phase. The heart is squeezing its hardest, doing its most important work, but electrically, the surface recording says nothing is happening.
Silence on the surface, but massive mechanical action underneath. And that little flat line, the part between the end of the QRS and the start of the T wave, it's called the ST segment. And doctors look at that line very, very closely.
Why, if it's supposed to be flat and silent?
Because it should be flat. If that ST segment is elevated, if it's pushed up above the baseline, or if it's depressed and sagging below, that is the classic textbook sign of a heart attack.
A STEMI.
A STEMI and ST elevation myocardial infarction.
So if that line isn't flat during the so-called silent phase, it means electricity is, what, leaking somewhere?
Exactly. It implies there's a current of injury. Some part of the heart muscle is damaged and isn't fully depolarizing like the rest. So there's a constant electrical difference, a constant flow of current, even during the phase that's supposed to be electrically uniform.
Wow. Okay, now speaking of missing waves, I have a mystery for you from the text. We've talked about the P wave, which is atrial depolarization, and the QRS, which is ventricular depolarization. We have the T wave, which is ventricular repolarization.
Right.
Where is the atrial repolarization? Where's the atrial T wave? The atria have to reset too, right?
Yes, the case of the vanishing wave. It exists. I mean, the laws of physics demand it. The atria absolutely must repolarize so they can get ready for the next beat.
So why don't we see it on the chart?
It's purely a matter of unfortunate timing and relative volume. The atria repolarize about 0.15 to 0.2 seconds after the P wave finishes.
Okay.
Now, if you look at the timeline of a normal ECG, what else is happening at that exact moment?
The massive QRS complex is happening.
The massive QRS complex is happening. It's getting completely drowned out.
So the signal is there, but it's just buried.
Completely buried. The electrical signal from the ventricles depolarizing is so much stronger, so much larger than the signal from the atria repolarizing that the atrial T wave is it's lost in the noise. It's completely obscured by the much louder signal.
It's like trying to hear someone whisper while a jet engine is taking off right next to you.
That is a perfect analogy. The only time we might actually see an atrial T wave is in certain very specific pathological conditions, like a complete heart block where the timing between the atria and ventricles gets disconnected. But in a normal, healthy heart, it's invisible.
Now, I want to pivot for a second to the paper itself, the actual graph. We've talked about the shapes of the waves, but we haven't talked about the grid they're printed on. Because when you see an ECG, it's always on that pink or green graph paper with all the little squares. And that's not just for looks, it's a ruler.
It is a precise scientific instrument. We call it the calibration. Without that grid, the squiggly line is just art. With the grid, it's data.
Okay, let's break down the axis. The horizontal axis is time, right?
Horizontal is time, and the standard speed for an ECG recording machine is 25 millimeters per second.
So if I'm looking at those thick, dark, vertical lines on the paper.
Each of those dark vertical lines is 5 millimeters apart. So at a speed of 25 millimeters per second, that 5 millimeter distance is equal to 0.20 seconds.
Okay, so one big box is 0.2 seconds. And then inside those big boxes, there are 5 tiny little squares.
Right. So if you divide 0.20 seconds by 5, you get 0.04 seconds for each tiny little square.
That is incredibly precise. 4/100ths of a second.
It has to be. In cardiology, a delay of just 0.04 seconds, a single tiny box, can be the difference between a normal diagnosis and a series conduction block diagnosis. The timing is everything.
And the vertical axis, that's voltage.
Vertical is voltage. The standard calibration is that 10 small divisions up or down so. 2 large squares equals 1 millivolt or 1 MV. Up is positive, down is negative.
Now here's a number from the text that really surprised me. We talked earlier about that monophasic action potential, the recording you get if you're right on the heart muscle membrane. The text says that voltage is about 110 millivolts.
That's the true power of the cell, yeah. 110 millivolt. That's the internal battery voltage.
But when we look at the ECG recorded from the skin, from my arm or my chest, the QRS complex, the biggest wave, is only about 1.0 to 1.5 millivolts.
It's a huge drop.
It's massive. It's like 100 times smaller. Where did all the electricity go?
It just dissipates, it gets attenuated. Remember, the electrodes are far away from the heart. The current has to travel through the lungs, which are full of air and are actually a pretty bad conductor, then through the fat, the muscle of the chest wall, the skin. By the time that signal reaches the surface, it's a shadow of its former self.
So the P wave is even tinier.
Much, much smaller. A normal P wave is typically just 0.1 to 0.3 millivolts, a tiny little flicker.
And the T wave.
Usually somewhere between 0.2 and 0.3 millivolts.
It really highlights just how incredibly sensitive these ECG machines have to be. They're picking up a fraction of a millivolt change on the surface of your skin to tell you what's happening deep inside your chest.
And that sensitivity is what allows us to calculate not just the shape, but the rhythm. This is where the real diagnostic math comes in. We use these intervals, the time between the different waves, to diagnose all sorts of problems.
Okay, let's talk about the first big one, the PQ interval. The text sometimes calls it the PR interval.
Yes, often PR, because the Q wave, that first little downward dip, is frequently absent, so it's easier to measure to the R wave.
And it's measured from the start of the P wave to the start of the QRS complex.
Correct. So from the beginning of the atrial trigger to the beginning of the ventricular trigger.
So it's the travel time.
It is the travel time. It tells us exactly how long it takes for that electrical signal to get from the atria through that little gatekeeper called the AV node and down into the ventricles.
And what's a normal travel time?
A normal value is about 0.16 seconds, just under one big box on the grid.
Why is that delay there? Why doesn't the heart just fire everything all at once?
That would be very inefficient. If you fired everything at once, the atria and the ventricles would try to squeeze at the same time. The big valves between them would slam shut, and the atria wouldn't be able to push that last little bit of blood down into the ventricles.
You'd lose that final top off.
Exactly.
Yeah.
You need that little atrial kick to completely fill the tank before the main pump fires. That 0.16 second delay is crucial. It gives the ventricles time to fill completely.
So if that interval is too short, let's say less than 0.12 seconds.
That means a signal found a shortcut. It bypassed the gatekeeper, the AV node. The timing is off. The ventricles fire before they're fully full, and your cardiac output drops. You see this in conditions like Wolff-Parkinson-White syndrome.
And if it gets too long, more than 0.20 seconds.
That suggests a blockage, what we call a heart block. The gatekeeper, the AV node, is either diseased or just falling asleep on the job. The signal is getting held up for too long before it's allowed to move on.
Interesting. Okay, what about the QT interval? That's from the start of the Q wave to the very end of the T wave.
Right, so that covers the big spike, which is depolarization, and the recovery mount, which is repolarization. It represents the total duration of ventricular electrical activity, from the moment they start to get the signal until the moment they are fully relaxed and reset.
And then that's normally about 0.35 seconds.
Aptly, yes.
Doctors worry a lot about long QT, don't they? I hear that term in drug commercials all the time. Do not take this if you have a history of long QT syndrome.
They do, and for good reason. If that QT interval gets stretched out for too long, it leaves the heart in a vulnerable state. There's a specific window during the T wave, what we call the relative refractory period, where the heart is electrically unstable.
A window of vulnerability.
Exactly. And if a stray electrical spark, like from a premature beat, hits during that vulnerable window of a long QT, it can throw the heart into a chaotic, twisting, lethal rhythm called torsades de pointe.
Which can be fatal?
It can be. So keeping that QT interval nice and tight is critically important.
Okay, let's do a little deep dive math. The text gives us this really neat trick for calculating heart rate just by looking at the grid.
The reciprocal trick.
It sounds like a magic act, but it's really just simple algebra.
It's simple, but incredibly useful at the bedside. The heart rate is just the reciprocal of the time interval between two consecutive beats.
So the RR interval, the time between the peak of one spike and the peak of the next one.
Correct. So let's say the distance between two R waves is exactly 1 second. That's 5 big boxes on the paper.
Okay, so if one beat takes 1 second, then in 60 seconds you'd have 60 beats. So 60 beats per minute.
Easy. Now, what if the spikes are closer together? Let's use the book's example. The interval is 0.83 seconds.
Okay, let me grab my mental calculator. You just do 60 divided by 0.83, and that comes out to roughly 72.
72 beats per minute. Exactly. So just by counting the number of boxes between spikes, a doctor can instantly and accurately estimate the heart rate without having to wait a full minute to count pulses.
That is cool. It turns a visual pattern directly into a hard number.
Everything about reading an ECG is about converting patterns into data.
Let's shift gears a little. We've been talking about the heart as if it's this line on a page. But it's a three-dimensional object sitting in a chest that's filled with conductive fluid. The source material uses this great term, syncytium.
Yes, the heart operates as a syncytium, which is a fancy way of saying that even though it's made of millions of individual cells, they're all so tightly connected electrically that when one fires, the signal spreads to all of them almost instantly.
So it acts like one single giant cell.
Functionally, yes. And because of this, when the stimulation starts in the center of the heart, that wave of electronegativity, the negative charge on the outside, it sort of leaks out into the surrounding fluid.
And this is where figure 11-4 in the text comes in. It shows the flow of current around the heart. It's not a straight line. It's these big looping elliptical paths.
Right. Think of the heart sitting in a bathtub full of salty water, which is basically what your chest cavity is. The current flows from the negative area, the depolarized part, to the positive area, the part that's still polarized, in these big looping lines through the fluid.
And there's a general direction to this flow, right? This is the whole vector concept.
In a normal, healthy heart, yes, there is a very predictable average direction. During the main part of the beat, the QRS, the base of the heart, which is confusingly the top part, is depolarized first. The apex, the pointy tip at the bottom, is one of the last parts to depolarize.
So the base at the top is negative, and the apex at the bottom is still positive.
Correct. And current flows from negative to positive. So the main river of electricity in the heart flows from the upper right down towards the lower left tip.
From base to apex, upper right to lower left.
That is the dominant vector. We call it the mean electrical axis. And knowing that direction is absolutely critical for understanding how we hook up the leads.
This leads us, pun definitely intended to, the triangle of leads.
Einthoven's triangle.
This sounds like some kind of secret society, but it's really just basic geometry.
It's the foundation of modern cardiology. A Dutch physician named Willem Einthoven developed this system more than 100 years ago, and we still use it every single day. We use what are called bipolar limb leads.
Bipolar just means two poles, right? Two wires creating a view.
Yes. Each lead isn't just one wire. It's a specific viewpoint created by comparing the electrical potential between two different wires. It's measuring the difference between point A and point B.
Okay, let's walk through the three standard leads from the text. Lead I.
Lead I connects the right arm to the left arm.
Right arm, left arm.
Yep.
Okay. Which one is the negative terminal and which is the positive?
By convention, the negative terminal is connected to the right arm. The positive terminal is connected to the left arm.
So if the river of electricity is flowing towards the left arm, which is the positive electrode, the graph goes up.
Correct. When the left arm becomes positive relative to the right arm, the pen goes up. And since the heart's current generally flows somewhat to the left, lead I usually shows a nice positive upward wave.
Got it. Okay. Lead 2.
Lead 2 connects the right arm to the left leg.
And the right arm is the negative one again.
Yes. For lead 2, the right arm is the negative terminal and the left leg is the positive terminal.
No, wait a second. We just said the main flow of electricity in the heart is from the upper right down towards the lower left.
Exactly. And lead 2 connects the upper right part of the body, the right arm, to the lower left part, the left leg. It aligns almost perfectly with the natural flow of current.
So it's looking right down the barrel of the electrical river.
That's a great way to put it. And that's why lead 2 usually has the biggest, tallest, nicest looking waves on the ECG. It's capturing the full force of the current because its viewpoint is parallel to the current's path.
So lead 2 is kind of the crowd favorite.
It is. It's often used as the standard reference lead for rhythm strips for that very reason. If you're just looking at one monitor, you're probably looking at lead 2.
Okay, and then finally lead 3.
Lead 3 connects the left arm to the left leg.
So now the left arm becomes the negative one.
Yes, relative to the leg. For lead 3, the left arm is the negative terminal and the left leg is the positive.
Okay, so we have these three distinct views. One looking across the top of the chest from right to left, that's lead 1. One looking diagonally down from the right shoulder to the left hip, lead 2. And one looking diagonally down the left side from the left shoulder to the left hip, lead 3.
And if you draw lines connecting those 3 points, right arm, left leg, you create an equilateral triangle with the heart sitting right in the center, acting as the electrical source. That is Einthoven's triangle.
I notice we're using the right arm, and left leg. What about the right leg? What's its job?
Ah, forgotten limb. The right leg electrode is just the ground.
It's just the ground wire like on an appliance?
Exactly. It doesn't participate in creating any of the views. Its job is to stabilize the recording and remove electrical interference from, the 60-cycle hum, from the power lines in the walls or the fluorescent lights in the room. It's just there to keep the signal clean.
Poor right leg. No glory. Now, this brings us to the law, Einthoven's law. This was the part of the reading where I really felt like I was back in physics class, but it's actually incredibly elegant when you see it work.
It's mathematically beautiful. The law simply states that at any given instant in time, the electrical potential recorded in lead I plus the potential recorded in lead 3 will exactly equal the potential recorded in lead 2.
Lead I plus lead 3 equals lead 2.
That's it.
Let's prove it. I want to run the numbers like they do in the text. The book gives us a specific example from figure 11 to 6. It gives us hypothetical voltage readings at the limbs themselves.
Right. Let's just assume, for one instant in time, that the electrical potentials at the limbs are these specific numbers. The right arm is at medical 0.2 millivac. The left arm is at plus 0.3 millivac. And the left leg is at plus 1.0 millivac.
Okay, so let's calculate the voltage for lid 1. Lid 1 is left arm minus right arm.
So that would be plus 0.3 minus 0.2. And of course, subtracting a negative is the same as adding. So 0.3 plus 0.2 equals plus 0.5 milliV.
Okay, so lead 1 is 0.5. Now for lead 3, that's left leg minus left arm.
Okay, so that's plus 1.0 minus plus 0.3, which equals plus 0.7 milliV. So lead 3 is 0.7.
So according to Einthoven's law, lead 2 should be the sum of those two. 0.5 plus 0.7, that equals 1.2.
Let's check it. Lead 2 is defined as left leg minus right arm.
So that's plus 1.0 minus 0.2, which is 1.0 plus 1.2, which is 1.2 milliV.
It works.
It works. The math holds up. That's actually really cool.
And what this tells us practically is that these leads are, in a way, mathematically redundant. If you know any two of them, you can always calculate the third. But more importantly, it confirms that they're all looking at the very same electrical event, just from slightly different angles.
And what do those different angles tell you? In the diagrams, lead 2 is usually the tallest. But what if, say, lead I was the tallest? What would that mean?
That would mean the main river of electricity has shifted its course. Instead of flowing mostly down towards the foot, it's flowing more horizontally towards the left arm. We call that a left axis deviation.
What could cause that?
A few things. It can be normal, like in pregnancy, when the baby pushes the diaphragm up and physically tilts the heart to the left. Or it could be pathological, like if the left ventricle muscle has gotten too thick from high blood pressure.
And if lead 3 were the tallest?
Then the current is pointing more straight down towards the foot. That's a right axis deviation. And it often happens when the right side of the heart is enlarged or under strain.
So just by looking to see which of those 3 waves is the tallest, you can get a rough idea of which way the heart is pointing electrically. It's like a compass.
It is exactly a compass for the heart's electrical field.
Now, that's just the standard triangle.
Sure.
But a modern diagnostic ECG uses more than just 3 leads. The text mentions the 12-lead system.
The 12-lead ECG is the gold standard for diagnosis today. It takes those 3 standard limb leads we just talked about, IAGM3, and then it adds 2 more sets of views.
The augmented leads.
Yes, the augmented leads, AVR, AVL, and AVF.
I noticed in the diagram that AVR is weird. The text points out that it's inverted. The whole thing is upside down.
It is, and for a very logical reason. Think about what it's looking at. AVR stands for augmented vector right. It's looking at the heart from the perspective of the right arm.
What we already said, the current flows away from the right arm. It flows down and to the left.
Exactly. The main electrical force is running away from the AVR electrode. And our rule is, when current runs away from a positive electrode, the pen on the graph goes down. That's why AVR looks like a mirror image, an upside-down version of the other leads.
So if you see an ECG where the P wave in AVR is positive, where it's an upward bump, what does that mean?
Well, it could mean the patient has a very rare condition called dextrocardia, where their heart is on the right side of their chest. But 999 times out of 1,000, it means the technician put the right arm and left arm stickers on the wrong arms. It's the most common technical error in performing an ECG.
So it's built-in quality check. And then we have the chest leads, V1 through V6.
These are the precordial leads. They are placed in a specific pattern directly on the chest wall, right over the heart itself. They give us a horizontal cross-sectional view. So while the limb leads look at the heart from the edges of the body in a frontal plane, up and down, the chest leads look at it from the front and wrapping around the side in a transverse plane.
It's like having cameras all around a football stadium instead of just at either end zone. You catch every possible angle of the play.
That is exactly the goal, because a heart attack might only affect a small part of the back wall of the heart or the bottom wall. If you only have one camera angle, one lead, you might miss it entirely.
That brings up a really great point about missing things. A standard ECG in a doctor's office is just a snapshot. It takes, what, 10 seconds to record?
If that, just a few beats.
So if I have a heart problem that only happens when I'm, say, running for the bus or when I'm stressed out at work, a resting ECG taken in a calm room is probably going to look totally normal.
This is a huge, huge problem in cardiology. We call them transient arrhythmias. The patient feels dizzy, they feel their heart racing, they feel palpitations, they go to the doctor, they run an ECG, and it's perfect because the event is over.
So how do you catch the ghost? How do you record something that's not there when you're looking?
You use ambulatory electrocardiography. You basically make the ECG machine mobile and have the patient wear it.
The text lists a few different levels of this technology. The first one is the Holter monitor.
The Holter monitor, right. Named after Norman Holter, the biophysicist who invented it. It's a wearable recorder. You wear the electrodes on your chest and a small box on your belt, usually for 24 to 48 hours.
So it records every single beat for 1 or 2 full days.
Every single beat, which adds up to about 100,000 to 200,000 heartbeats. Then you return the monitor, and a computer analyzes all that data to see if there were any strange pauses, extra beats, or irregular rhythms while you were going about your normal day.
But what if your problem only happens, say, once a week or once a month? A 2-day Holter is still going to miss it.
Then you step up to the next level, intermittent recorders or event monitors. These can be worn for weeks or even a month. But they don't record continuously because the memory would fill up too fast. The patient has to press a button when they feel the symptom.
I'm feeling dizzy right now. Click.
Exactly. And the device is smart enough to save the recording from the few minutes before you press the button and a few minutes after. The idea is to catch the event in the act.
But the ultimate spy gadget mentioned in the text is the implantable loop recorder.
This is just fascinating technology. It's about the size of a large paperclip.
A paperclip. That's tiny.
Very small. And they don't even do surgery to put it in. They numb the skin on the chest and just inject it, slide it right under the skin. It's a procedure that takes maybe 5 minutes in an office.
And how long does that little thing last?
The battery life is typically 2 to 3 years.
3 years. Wow.
It just sits there silently monitoring the heart's rhythm, 247, for years. It can be triggered manually by the patient with a little remote if they feel symptoms. Or, and this is the really clever part, it can trigger itself.
How?
You can program it. If the heart rate drops below, say, 40 beats a minute or spikes above 180, it automatically wakes up and records the event, even if the patient doesn't feel it or is asleep.
So for a patient who faints randomly, syncope, and no one can figure out why, this little paperclip could solve the mystery.
It has completely revolutionized the diagnosis of unexplained fainting. It catches the heart stopping for a few seconds or racing chaotically when no one else is looking.
And the text even mentions more modern tech, like sending this data over telephone lines or the internet.
Yes, telemetry. We can now monitor these devices remotely. This is crucial for detecting dangerous but often silent conditions like atrial fibrillation.
And why is catching atrial fibrillation or AFib so important?
Stroke prevention.
Yeah.
In AFib, the top chambers of the heart, the atria, just quiver instead of squeezing properly. The electrical signal is totally chaotic.
And if they're quivering instead of pumping?
Blood stagnates in them, and stagnant blood forms clots. If one of those clots breaks off, it travels from the heart straight up to the brain, and that causes a stroke.
So if that implantable loop recorder catches this quivering rhythm, even if the patient can't feel it,
The doctor gets an alert on their computer, they see it on their remote monitor, they call the patient in, put them on blood thinners, and they can potentially prevent a devastating stroke before it ever happens.
it's just amazing to think about the whole progression here. We started this conversation with a single ion moving across a single cell membrane, the little red and white zones on a diagram.
The physics of the spark.
Then we zoomed out to the whole heart muscle, the syncytium, creating this river of current.
The biological generator.
Then we built this elegant mathematical triangle around the entire human body to measure that current from a distance.
The geometry of the leads.
And now we're implanting tiny computer chips the size of a paperclip under our skin to record that signal continuously for years and beam it to a doctor.
It's the complete narrative of how medicine has learned to listen to the body's most fundamental language.
So what does this all mean for you, the listener? Why does knowing about P waves and ST segments and QRS complexes matter if you aren't a cardiologist?
I think it demystifies our own biology in a really powerful way. That beep, beep, beep on the monitor isn't magic, it's physics. It's predictable, it's measurable, and it's ultimately understandable. The ECG is a voltmeter for the soul's engine. It translates these invisible shifts of ions into a language that doctors can read to save lives. And when you understand that, you appreciate how intricate and how incredibly resilient your own heart is. It's doing this precise electrical dance roughly 100,000 times a day, every single day, without you even having to think about it.
That is a humbling thought. 100,000 QRS complexes a day.
Each one perfectly timed, most of the time.
Before we wrap up, here's something that's been kind of stuck in my head since we started. We talk a lot about how the body is a conductor, right? A bag of salt water that lets the heart's signal reach the skin. And we talked about how Einthoven's triangle relies on that conductivity being relatively uniform. So here's my provocative thought to leave you with. If our heart's broadcast relies on the fluid and tissue in our body, how do changes in our own body composition subtly change the signal that's recorded? If I get dehydrated, if I gain 20 pounds of muscle or 20 pounds of fat, does the volume or the clarity of my heart's broadcast change just because the medium it's traveling through has changed?
That is a profound question, and the answer is yes. We know that fat is an insulator and it dampens the signal. Obese patients often have what we call low-voltage ECGs. We know that extra fluid in the lungs or around the heart can short-circuit it. The heart might be playing the exact same song, but the acoustics of the room, your body, can completely change how it sounds on the outside. It's definitely something to ponder.
The acoustics of the body. I love that. Well, that wraps up our deep dive into the electric heart. We hope you'll never look at those squiggly lines the same way again.
Thanks for listening.
Catch you on the next deep dive.